So we just got done talking about deep brain stimulation. I went through a lot of slides there that really provide you information about it, and I didn't really want to go over it because I think you get the idea that it's a complicated intervention. It might be absolutely critical for some, but we have to be careful about choosing the right patient for that. I always get a question about complementary and alternative interventions, and I've made a list of them all here. So there have been times where we thought about nicotine might work, and we've also thought about mecamelamine, which was a anti-nicotine. Both of those, I think, have kind of gone by the wayside. We've used a variety of medicines, including, marijuana and the cannabinoids. There's always been a question about why boys have more Tourette than girls do, and so people were wondering about whether it's boy hormones, and so there have been people who have even tried to use an anti-boy hormone, flutamide. And guess what? It works short term. But men will not be repressed. We are biologically driven in that particular way. Omega-3, it probably does something to mood, anxiety, affective something. But it's a changing field. The quality's not there. There's the good compounds and the not so good compounds. There's the different types. So I think you have to have somebody who's kind of invested in it. But it is available at nutrition stores or over the web. Maybe something there, but I wouldn't expect miracles. But you might have a kind of quality, a calming kind of quality from the medicine that might be quite subtle, and it's not bad for your heart either. Health supplements. You hear a lot of families talking about special diets. The problem is the studies to evaluate that are usually too small. They're too small and the effect is small. So if you have a small study where only about 20% of people benefit versus 5% in the other group or 10% in the other group, the difference between groups isn't large enough for people to get too excited about. The problem is that people who do these dietary changes, some of them actually believe that it makes huge changes in their kids' outcome. And they try it on, and they try it off, and they try it on, and they try it off, and they become convinced that it's valuable. And I'll never argue with somebody who does that, but I will ask them to not spend too much money doing it, because I have seen people remove all of their carpet from their very large home because there was a carpet allergy. Cost $20,000 to $30,000. Those kinds of interventions, I ask people if they're thinking about alternative interventions to think very carefully about those large dollar amount interventions, and to be very skeptical. There's a website called Quack Watch. Man, if you haven't gone to look at Quack Watch, it's a real education about kind of science and evidence and the selling of snake oil. Do you know what no legs means? These are treatments that have shown some benefit, but they ain't going anywhere. So the ziprasidone trial that was done by Randy Salee was done in a very small number of kids, and it was done with a very low dose, 20 to 30 milligrams. Now that's the starting dose. People are using it for tick suppression, are getting upwards to 80 to 120 milligrams. At that point, it doesn't quite look like the good medicine anymore. Pergolide is a medicine that's no longer on the market, but was used. No, I take that back. Pergolide was a medicine that was used. It's a dopamine enhancer. So you usually think about dopamine enhancers like stimulants making tics worse. But this was an enhancer of a particular type that actually worked on the upstream nerve to shut down release. And so there was this idea that if you could work on that upstream nerve to decrease release as opposed to block dopamine, that you might have some benefit. But even Don Gilbert, who did this study, doesn't use it. And the baclofen story, there are people who are using baclofen. It is a kind of a muscle relaxant, central nervous system depressant. But that study didn't really work on tick severity. It worked on general well-being. And this may be a little bit like benzodiazepines or maybe like tricyclics that actually have an effect on tick severity by improving well-being by reducing anxiety. So these are treatments. Your doctor may recommend them, but these are not winners. Non-pharmacologic strategies for ticks. How many people have heard of CBIT, the behavioral treatment? Really? The rest of you are just haven't heard? Really? Let's do that show of hands again. All right, we're rolling. All right, so let's talk a little bit about the ticks in the environment. We know ticks are worse with excitement and stress. Have a kid with Tourette's study for a test, ticks are going to go up. Take a kid to Disneyland. Oh my goodness. The story usually goes like this. They're 8, they got diagnosed in January, took them 3 months to see a doctor. During that period of time, everybody's fretting and upset. They see the doctor in April or May. The doctor says, yep, it's a tick disorder. Everybody feels relieved. The school was confused. The family was confused. Everybody was upset. They finally get through the school year and they say, you know, we really deserve a break. Let's take that dream trip to Disneyland with our 8-year-old who had a tough time this year in school. Oh, man. Please, just take him fishing on a very calm lake with no fish. Because as soon as they catch the fish, they're going to get excited and their ticks are going to get away. You just want them to do the repetitive casting over and over and over. That's what's really good for Tourette. Boring, methodical, over and over. I'm just teasing. Fatigue. So when do kids' ticks get worse, right? When they're doing homework. We're going to talk a little bit about that example in a bit. Paying attention to ticks. Why do you do that? Do you ever do this? Have you had this tick? Those kinds of interactions will raise tick severity. So teachers, it's one of the reasons why we want teachers not to pay too much attention to the ticks. We don't want them to go or ask Billy why he's doing that or tell Billy to stop doing that, because we know it actually makes it more difficult for Billy to stop because attention to ticks makes them worse. Free to tick environments. What is that? Well, we just got back from the national meeting, and when I first went to the national meeting of the Tourette Syndrome Association, it was a different meeting than it was this last time. We saw many young adults, teens, come to this meeting and have a lot of ticks. And what they would describe was, this is the first and only place where I can really go and know that I'm going to be accepted, even if I have ticks. And the hotel that we used to use, we used to put out a flyer at the desk that essentially said, you know, we're having the Tourette Syndrome conference here this weekend. And, you know, just to alert you if you hear noises or you see stuff, that's kind of what we're about this weekend. And there was a little bit of, you know, we'll help arrange for other hotels if it disturbs you too much. But there were a lot of ticks there. And there were some folks who once we started doing this behavioral treatment, said, you know, I used to really like going to that meeting, but I was too comfortable ticking there, and it took me a long time to settle myself down after I had been there. And the comment was, I didn't know that I was actually doing anything in my life that I was actually letting go of when I was at the conference, and I wasn't really clear about what I was doing after the conference to get back to my baseline. But I did notice that in that environment where there were no real consequences, that I just let go, and it was uncomfortable. I don't like that feeling anymore. I like the stability. So there is something about permission to tick that I think we have to be very careful. We don't want to criticize or punish, but we probably also don't want to give permission. So what I ask kids to do is I say, you know, this is a tough thing that you've got. You can't really control it, but you got to find a way to really live with it. And so the words that I use are find a way. We had a little girl came in and she had gotten a bracelet that said find a way on it. And she used that whenever she was struggling to kind of figure out something for herself that she could use to find her way. So that empowering statement for me is a much better way to work with. It's vague, doesn't really mean much, but it has a different message than you can't control it. And I think that difference makes a difference in terms of how people focus on mastering whatever it is they can master, that people will describe mastering, believe it or not. So we also know that tics are really good in calm, focused activities. So Peter Hollenbeck will describe, he's a long-distance runner. When he's the former co-chair of the Scientific Advisory Board, the neuroscientist at Peru. When he's running and he gets in that zone, his tics go away. When he looks at his watch to see what his time is, or somebody runs past him who he thought he was going to beat in the race, as soon as for some reason that surface of the brain gets engaged, when we move out of that zone and we start thinking, tics rise. Deep relaxation. So we hear every once in a while reports about biofeedback, neurobiofeedback, deep muscle or relaxation, progressive muscle relaxation, self-hypnosis, you name it, all of those yoga, all of those kinds of things that essentially train people to move their mind into a quiet mental state. They're all good for tics. So what we're doing in the behavioral treatment now, especially when you're dealing with a 9-year-old boy who has trouble getting his mind into that zone, what we're saying is you can do relaxation, but the whole point of relaxation is to get to that cool-headed place. If you're doing neurobiofeedback, you want to get to that cool place. If you're doing muscle relaxation, you want to get to that cool-headed place. So we're teaching people that the goal of this is not just to scrunch and let go of your muscles, but your goal is to do that to the point where your head gets to that cool, calm place, because when your head is there, you will experience fewer tics. And I think that's been helpful for some folks. They just said, well, I didn't know what I was squeezing my muscles for. You know, progressive muscle relaxation starts with your toes and goes up to your feet and into your legs and then your whole body. But the whole point of doing that is to get yourself into that kind of zone. And so fishing, to bring that back again, is a zone activity. I mean, that kind of repetitive thing is just, it's so wonderful. People relax and get calm. Anyway, I also like inhibiting environments. So I like kids to live in environments that are not punishing, but where the expectation is for them to manage their tics. And it's amazing. Kids will tell you that they come up with all kinds of different strategies to manage their tics. When we first started talking this way with the behavioral treatment, we heard from many adults about strategies that they would use. We had one guy who was a musician, probably pretty well known in the Tret world, and he described before a performance, lots of tics. Once he got into his zone, playing his musical instrument, his tics went down. He also said, because he was more of a jazz improvisational type, you know, how the improvisational people, they kind of really get into that zony, flowy thing. Well, he's actually found ways to put himself into that quiet mental state when he's in social situations. So he actually demonstrated to me his capacity to kind of drop himself, and it really looked like self-hypnosis, drop himself into a quiet mental state, and his tics just disappeared as soon as he did it. And I thought, you know, that's kind of interesting. He said he used it as a skill in social situations when he's excited and kind of overstimulated. He's ticking a lot, and he just needs to be relieved of all the muscle tension, that he uses this strategy to quiet his brain. So we've heard lots of stories like this since we've been doing the behavioral treatment. And if you think about what we're doing on the behavioral treatment side, is we're trying to take all of this collective experience, right, bottle it up with the very best of behavioral theory, making sure that it makes human, logical, and reinforcement sense, and then teaching kids, now we're getting down to 6, 7, and 8, at the youngest ages possible, to use these strategies to manage their tics better. That's all it is. Nothing more, nothing less. taking the knowledge about what makes tics better and what makes tics worse, packaging it in a form so that people can learn how to do it, and then teaching them how to do it and then setting them free to use the strategies. So let's do the theoretical model. Why do we think it works? And then talk about the various components. So the first time a kid tics, he doesn't notice it and nobody else does either. But once he's done 2, 3, 4, 5 tics, the teacher will begin to stare at him. He'll be able to say, boy, I'm being stared at. They're staring at me because of the things I'm doing with my eyes. The parents will, dad will look at mom and say, did you see that? Mom will, yes, it's been here for 3 days now. I've been keeping count. They're all staring at the youngster, right? I think I got to call the doctor. Reminds me of your father. He had the same thing. It must be your fault. Those kinds of discussions are the things that start happening. And the kid becomes increasingly self-conscious. And if you think about what happens when you're self-conscious, you begin to anticipate something happening in situations where it's happened before, right? So, if you've spilled soup at a dinner party on yourself, next time you go to a dinner party, you're going to be a little bit more careful with how you do the soup. Those kinds of experiences are exceedingly human. So what happens to the kid who's being stared at and who's getting self-conscious about his tics? He begins to figure out, this isn't conscious, this is just kind of our humanness, if you will. He begins to think about when he's going to have his tics, what makes him worse. He knows that teacher, when that teacher stares at him, that makes him the most uncomfortable, and his tics are more frequent then. So he goes into that classroom now anticipating that that teacher is going to look at him and that that's going to make the tics worse and it's going to make him more and more uncomfortable, and he better get a leg up on this tic thing because it's just going to be a terrible experience with that teacher on that day in that way. And there's some of us who actually think that that self-conscious experience is what leads to the development of that premonitory sensation, that kids then begin to tune into their tics and they begin to notice that there might be a little physical something in their shoulder that occurs just before they actually tic. So that process of self-consciousness, and it's negative, this is not a happy experience for the people who are experiencing it, leads to this premonitory sensation. And then what happens is, oh my gosh, I'm heading into the classroom, I'm feeling this thing in my shoulder, let me see if I can get rid of it before I actually go into the classroom. So you begin to see people ticking in response to the premonitory sensation. Well, what we know from human behavior, that if you have a difficult experience and you do something to get rid of it, you actually, and it works to get rid of it, the next time you have that experience, you will do that thing again, right? It's called negative reinforcement. OCD is based on negative reinforcement. You have this idea that if you don't wash your hands, the whole world is going to die. So you wash your hands, you look at them, you say, well, the stakes are really high. I know my hands are clean, but I better just do it one more time. And I know they're clean, but, it's just too important. Let me do it again. And so what happens is you get into this idea of doing something to get rid of a negative experience, and the same pattern happens with tics. So what we're trying to do with this is to disrupt the connection between that sensory experience, if you will, and the tic by giving the person something else to do. We were at lunch again today, and this person was describing that when they have tics, they clench their fists like this. Or they knew somebody who clenched their fists like this as a way of doing something when they felt the tics coming on, and they did that until that sensation goes away. That's exactly what we're teaching kids to do, except we don't want it to be so obvious. This is a pretty obvious behavior, kind of sticks out, and some people in some settings might actually view it as kind of ominous. But still, this person had discovered a way. And so what we're trying to do in the treatment is to help people figure out how to do these kinds of skills. So what we do is we teach them, and they teach us about their tics. So what we're trying to do is learn everything we can about the kid's tic behavior, when it's better, when it's worse, what versions there are, what variation is there, how much of it is tied to some kind of sensation, what situations make it worse, what situations make it better. all the kinds of things, and we're writing like crazy trying to figure out what their tics are and trying to understand them in great detail. Then once we figure it out, then we ask them to do a competing response, which is a thing like this that they can do to disrupt between their experience of going to tick and actually ticking. The cool part about doing something like this is that once you do this, over time, if that sensation or feeling goes away, you can begin to get rid of this behavior because this is voluntary, right, where the tick really isn't. So when you think about what a competing response would be, you use something that's incompatible with the tick, something that's less socially noticeable, so you don't want people to do something that draws even more attention to them, and that they can do it for the required duration, which is usually about a minute or so. So here's some examples. But I'll give you some other examples that I like to do. The first kid that I saw the treatment demonstrated, Doug Woods did this kid. And he had, are you ready? Whoop-hoo! Whoop-hoo! That was his tick. So Doug said, well, so do you have any sense ahead of time that you're going to do this? Like, you have that premonitory thing? Kid goes, no. And I'm like, oh man, this is where are we going with this? Because he doesn't have an important part of the, what's Doug going to do? This was like pins and needles. So Doug, who's very smart, said, how did you know to get your hand in front of your mouth before you went woo-woo? Kid said, woo-woo, what do you mean? Woo-woo. Woo-woo. See how this is going? Slow motion. Kid was moving the hand before he made the sound. So the way the kid was trying to solve this noise was what I call white knuckle tick suppression. You know, clamp down on every muscle in your body to see if you can just control it. What Doug did is he said, I want you to focus on your hand, and when it begins to move up, I want you to use diaphragmatic breathing. So what does that accomplish? Well, so the kid is going into a difficult circumstance, right? He knows that he's feeling this hand begin to move, and so what he does is he begins to focus. Remember deep focused activities? He focuses on his hand. He's not doing white knuckle tick suppression anymore. He's focusing on his hand. Then the other thing Doug asked him to do is an incompatible motor movement, which was diaphragmatic breathing, breathing like you do in yoga, where you push your tummy out, drops your diaphragm, fills your lungs, you contract your stomach, pushes your diaphragm. Yeah, exactly. Dad's doing it over there. And you push it out. If you focus on that, that's yoga style breathing, right? You begin to focus on that, you're going to accomplish some relaxation. You're also focusing now on your hand and another motor movement. Those mental activities are incompatible with ticking. Does that make sense? So the kid's thinking about his hand, he's doing the diaphragmatic breathing, and he enters the situation and all of a sudden he's not ticking anymore. He gets none of that negative feedback. People aren't staring at him anymore. And slowly over time, he's begun to find a way to deal with the tic in the short term to decrease its intensity. He's found a way to manage it, if you will, not make it go away, but just manage it. And he can go into social situations now and feel much more comfortable, much less tense, feel like he's in charge of what he's doing. So that's it, not much more than that. It's a simple treatment too. It's a good treatment for doctors to teach because we're not as smart as psychologists, and we like things to be really, really simple. So I'll give you an example. 6-year-old. That was his tic. His 6-year-old solution. Are you ready? He jammed his whole fist in his mouth. He didn't get in trouble because of the tic. He got in trouble because it was, get your hand out of your mouth. 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 He was a nervous wreck. So what we taught him to do, and this took me, I tell you, because I know the treatment. I don't really do the treatment, but I know the treatment. I said, oh, can we just do this? You can walk around school all day like this. People will think, you know, you're going to burp or something or sneeze or cough or whatever, but it's an appropriate movement for you to make. And the cool part is you can press your tongue against that fat part of your finger to do that muscle thing. Kid said, yeah. And I said, parents, can you practice this at home? They said, yeah, we can practice this at home. So when he's doing the tongue thing at home, just remind him to, you don't even have to say anything. All you have to do is go like this, and he'll imitate that. So 10 days, 2 weeks later, that tick was gone. But more importantly, he felt like he could do something. He was empowered to do it. He was doing it at school. He stopped getting in any trouble. People weren't looking at him anymore, and over time, the tick faded. Now, whether that tick would have faded on its own, because they do come and they do go, the experience of him managing the tick was a positive one. Instead of getting in trouble for his solution, we taught him a solution that was straightforward, easy for him to do, comfortable, and at 6 years of age, worked for him. So that's why I like this treatment. This is a treatment that really doesn't take, you got to understand the basic principles of it, but once you understand the basic principles of it, it can be fairly simple to implement. Okay, the other cool part about this, and this is tricky, so you hang on. We look at how ticks play themselves out in the kid's environment. So we evaluate the ticks, figure them out, and then we wonder whether there are any provoking experiences or whether there are any social consequences for the experience. Oh goodness, here we go. So the example we use is a guy named Billy. He comes home from school. He's 8, 9, 10, something like that. His 15-year-old sister is sitting in the television room watching television. He bops in, and like all kids with ticks, after school they usually have this burst of tick behavior. He goes in the family room and he's moving around a lot and he's making sounds and noises, and his sister tells him to shut up and tells him to get the heck out of there, and he says, leave me alone, I have Tourette's syndrome, and she said, I don't care, you're annoying. And they get into this thing, and then Billy has enough and he says, Mom, and Mom comes in, and Billy says, you know, she's being mean to me. She's telling me to shut up. She's telling me to stop it. She knows that it's my Tourette and that I can't control it, but she's, you know, being mean. And the mom says, you know, we've had so many discussions, Julie, go to your room. Yeah, so Julie goes to the room, and then Billy goes over to the television and changes the channel. Kids get tired doing their homework. Oh, why don't you just stop for now? We'll bake some cookies. I'll give you a little back rub. If you can't get back to your homework, I'll write a note to the teacher telling them that your ticks were too bad tonight and that you shouldn't be held accountable for finishing your homework because your Tourette was too bad. Those kinds of experiences. We've had kids who get a lot of foot rubs in addition to back rubs when their ticks are bad. That kind of attending to tick severity, while intuitively perfect, there is no human being who wouldn't do that. Problem is, from a behavioral point of view, it actually reinforces or rewards tick severity. So what we're trying to do with kids who are in the treatment is we're saying, before you do your homework, why don't you go do your tick management exercises so that when you head into your homework, you're going to be in a good place. And what we'd like to be able to see you do is, if the ticks flare because you're tired, and we know you're a little tireder tonight because you had, you know, softball practice or whatever, we want you to try and practice doing your exercises while you're sitting in the chair doing your homework until you can see them quiet down a little bit. And then what happens is, once they do their tick management exercises, then we're all over them with cookies, back rubs, foot rubs. But how we sequence those rewarding experiences, we're rewarding, if you will, management efforts as opposed to rewarding, if you will, tick severity. Does that make sense? It is so subtle, but moms and dads feel so bad for kids who tick that they can't help going a little bit out of their way to do something extra special or extra nice for them when their ticks are really bad. Siblings of kids with Tourette get the game. Oh, here he goes again. He's doing that tick thing, and mom's going to do something like give him a back rub or bake some cookies. We've seen this a million times. So they kind of get it. So if your kids are kind of harping at you, you know, the unaffected sibling about kind of how you're managing the tick disorder, pay attention to that. They're not wrong. They understand this function-based stuff extremely, extremely well. So when I'm with a family, this is part of my assessment tool, my little 2x2 square. And we have positive reinforcement and negative reinforcement up top, and then we have internally reinforcing and externally reinforcing on the bottom. So this box is really that you feel that sensation in your shoulder, and you tick in order to get rid of that sensation. So that's negative reinforcement. It's because it's the internal sensation, it is internally negative reinforcement, right? Does that make sense? All right. So what we also talked about was external positive reinforcement. So the kid has tics, the parent gives them a back rub or bakes some cookies. Those are positive reinforcing activities that happen by an external force. Does that make sense? All right. Less common but important is there are some severe tics that we have seen actually function to help kids avoid situations. So the one where the tics with tiredness that help them avoid homework, that would be negative external reinforcement, because the noxious experience of homework gets relieved by avoiding. Does that make sense? We also have seen really loud tics kind of function in an interpersonal context to shut down discussion. So you're having a discussion about behavior or about something else, and all of a sudden the tics get really loud, and the parent just says, I can't deal with that right now. We'll just wait till your tics are a little quieter. So that they can actually become tics within the interpersonal process that kind of manage the flow of intense emotional stuff. Now, this is an interesting one, internal positive reinforcement. What the heck is that? That is when a tic might actually be potentially gratifying to the person internally. Now, I don't ever think about tics in that way, but this was a couple of years ago at the national meeting. They always seem to hold it in hotels that have these big atria, right? And I noticed, sitting in the bar, I noticed that there was one guy who always came through the atria, and whenever he was in the atria, he made these loud shrieking sounds. But as soon as he got down to the places where they had the acoustic tiles or outside, there was no sound. And I thought, you know, I bet there is something about hearing his voice. And when you talk to people about Tourette, they have this exquisite sensitivity to those kinds of environmental factors. And I just wondered, I never asked him, but just wondered whether there might have been some kind of feedback about hearing that sound that actually, not necessarily pleasant, but on some level kind of gratifying, because it didn't occur where it was dampened, and it didn't occur outside. So we don't see many tics like this. This is the most common. This is the thing that we address with treatment, and we do see occasionally where tics are used as or function as a strategy for avoiding activities. So when I'm with a family, especially when medicines aren't working or we're having trouble with the behavioral treatment, I begin to go to my little 2x2 square and try and figure out what kinds of other reinforcement strategies might be sustaining the tic severity. Does that make sense? All right. So this is a behavioral therapy study for kids, almost identical study for adults. We talked a little bit about what the training was. Oh, one thing, I have a therapist who doesn't do the competing response training anymore. He just does awareness training. So where they're better, where they're worse, what makes them better, what makes them worse, and then gives the instruction to find a way. So after the kid really learns a lot about his symptoms and what makes him better and what makes him worse, he empowers the kid to go figure out a strategy to do better in the situations where the kid wants to do better, and then report back. And there's a lot of encouragement and a lot of support, but doesn't really do competing response anymore. So what exact part of this is really important, whether it's the awareness training or the competing response training, kind of hard to know. This was the study. We're now up to 250 subjects because we have 126 kids and 124 adults. The same design, 10-week trial. And this is what patient number 1 looked like. That was before treatment. This is after treatment. He's such a much happier guy. All right, so this is the response rate in kids. 52% in kids, 53% and 18% in the comparison group. The comparison group wasn't empty. It provided 8 weeks of education about tics, Tourette's, everything you wanted to know other than what we taught in this condition. So we had one little guy at our site who got this and did pretty well with it and said, I want to go get that treatment now because I don't think I learned enough about Tourette's syndrome when I was in this condition. You just kind of helped me manage them, but I want to know more about this. This is very interesting to me. Were there moderators? Not really. Moderators are things that explain treatment differences. So kids who were on tick-suppressing medicine didn't do quite as well as the kids who weren't on those medicines. So if you've already lost, 10 or 15% of your tick severity, for some reason or another, they didn't do as well with the behavioral treatment to get rid of it. And I think there's a couple of explanations. Sometimes the medicines may make it more difficult for you to pay attention or to engage. Sometimes, at least in my experience with kids and families, is once they've made a commitment to a med treatment, it's very hard to engage them in a behavioral treatment too. It's like you have to think about meds and behavior at the same time. It's oftentimes easier to get people involved in a behavior treatment where they're not thinking about their medicine. Sometimes that decision, should I go up on the dose or should we work harder on the behavioral treatment, that kind of dichotomy for people ends up being kind of confusing to them. And we've seen this in other studies where the med-treated group doesn't work as hard in the behavioral treatment. And then guess what? Kids with ADHD didn't seem to do quite as well either. Do you know when we did this treatment? After school. Couldn't take them out of school. They had to do 8 sessions over a 10-week period. These were kids who were coming in, 4, 5, 6, 7 o'clock at night to do the treatment. When do stimulants stop working? 4, 5, 6. So Barbara Coffey in New York actually has a little sub-study where she's actually giving kids their ADHD medicine before they do the treatment so that they're able to settle themselves and be in control and participate in the active treatment. It's durable. So 87% of the kids who got better stayed better over the 6-month follow-up period. But this was really fun for me because there were kids who we did 10 weeks and they just stopped doing their exercises. They would come back for their monthly visit and their tics would come up again, and we were able to restart them and remind them of what they were to do and then knock them back down again. We had kids in our trial who continued to do their exercises afterwards until they felt like they had managed their tics to a point where they really weren't bothersome, and those kids stopped doing their exercises and continued to do well without doing their exercises. So the pathway of post-treatment, how kids use this skill over time, is also one I think that's interesting to us. One of the I don't know. Oh yeah, let me just do this first. So what does this all mean? Well, it kind of depends upon the audience. I have a very close colleague who is a psychologist trained at Stony Brook in New York, and she said, I don't know why you guys are getting so excited about this. I was doing this 20 years ago. We've been taking care of kids and adults with Tourette syndrome, teaching them this strategy. It's been in the literature forever. It's been psychologists, it's just old hat. Kind of took the wind out of our sails a little bit. The other interesting thing about this is that there's another kind of psychologist. So we had our anxiety and OCD cognitive behavioral therapists do this treatment. They didn't like it. Our cognitive behavioral therapists wanted to do thoughts and feelings and emotions, and this is a therapy where you do, try this. That's why it's good for doctors. We really don't want to hear too much about thoughts, feelings, and behavior. That's not true. But anyway, it's a different kind of treatment. So we have Leon Dorr, who's a neurologist in Alabama. Leon is trained, and his crew there, they use occupational therapists now to do this treatment. And if you think about that group of people, they're interested in the body. They have exposure to kids like tics because they do all that sensory integration stuff. And now we're teaching them the skill, this very muscle, behavior, physical-oriented treatment, breathing, relaxation, all those kinds of skills. They're taken to it like that. And what's cool about it is that there's no stigma associated with going to an OT, not like going to a psychologist or psychiatrist. And they like doing the treatment. There are OTs everywhere. And so the transition out of a physician's office into an occupational therapist is probably smoother than the transition out of a physician's office into a psychiatrist or psychologist. Psychiatrists, we're a little like psychology. There are some of us that kind of just naturally gravitate to this because, you know, we use the diabetes thing. You know, you use insulin for your diabetes, but you also have to do diet and exercise. And if you have Tourette syndrome, you may use medicine, but you also have to live right, think right, and be in the right environment to manage your tics well. While most folks in neurology are coming around and kind of get this, there's a few holdouts. There's a few folks who really think that talking about the behavioral treatment is not a good thing. And so we're struggling a little bit with that group. So you may hear naysayers out there, but that 254 subjects who have done this treatment now, or 250 subjects who have done this treatment, that's probably 4 to 5 times as large as any other treatment trial that's ever been done in Tourette. So we now have more data on behavioral treatment than we have on medical or medicine treatments. Primary care docs, this is right up their alley. This is, you know, you got a medical problem, you have to do lifestyle change as well as take medicines. It's just a no-brainer. Other medical professionals, nurses will get this, occupational therapists. We got our physical therapist representative here today. There you go, thank you. They get this stuff. It's just, there's something about the body that those professionals get, and the idea of using multimodal treatment, lifestyle change as well as medicine, is really the right idea for getting people better. Kids love it. I have a great kid story. One of the things that the naysayers say is, how can a kid be focusing on diaphragmatic breathing when he's supposed to be listening to the teacher? So I had this 16-year-old who had just done the treatment. I said, you know, what do you think? He said, I like it. It feels good. I'm better. And I said, well, you know, what's happening at school when you get the tics? I mean, if you're having to do your exercises in the classroom, I mean, how do you pay attention? And his jaw dropped. He looked at me and he said, what do you think it was like before? I said, well, what do you mean? He said, they were all looking at me. I got so nervous. I was so self-conscious. It made my tics worse. I didn't know what to do. I hated going to school. Yeah, you know, I have to kind of think a little bit about starting the breathing thing, but I don't have to think about it too much anymore. I'm getting kind of good at it. Nobody's staring at me. Nobody's talking about me. I'm feeling more comfortable. I'm less anxious. Man, this has been good for me. So I think sometimes when we think about this treatment, we think about it in kind of old-fashioned or kind of concrete ways, and need to really think about it as a complicated behavioral intervention. Families are a little uncertain about this because we've been selling this whole idea of don't pay attention to them, don't focus on them, don't tell them to stop, they're involuntary, they can't manage, and families are saying like, whoa, what are you telling me? You're telling me this thing and now you're telling me this thing, and it's kind of confusing to me. School personnel, this is where the big worry is once they read about a report in the newspaper that kids can control their tics or manage their tics through a behavioral treatment, you know, Mrs. Smith is going to look at Billy and say, stop it now, I read about it in the newspaper. So we've done all kinds of brochures and other kinds of educational efforts with teachers, but you know, Mrs. Smith wasn't good before, and she's probably not going to be good later. And so I think we have to understand that there's a group of people out there that you can try really hard to bring them around. Just may not happen. Advocacy organizations, oh my gosh, the Tourette Syndrome Association, I love them so much. But they have to say you can't control it and behavioral treatments work. And at some point or another, you know, those two kind of come together in a place where it's not really quite comfortable yet. We're creating a new language to actually make that stuff make sense now, but it really requires, you know, that 2x2 square? It really requires that our language not be cortical thalamostriatocortical circuits, but it's got to be about internal and external positive and negative reinforcement. We've got to learn a whole new way of thinking about where tics come from, what sustained them, and what the issues are. So I got this one. We're changing our advice. So we used to say ignore the tics, now we're saying become more aware. Can't be controlled, learn to manage. Don't punish. Well, we don't ever want any kid to be punished, but we really want to reward kids for trying to successfully manage their tics. Behavioral treatments don't work. Please use as many behavioral strategies as you possibly can to find your way to manage your tics for yourself. Don't try to suppress. We actually don't try and white knuckle suppress. That actually makes tics much worse. The tension that rises in the body when people do white knuckle, it feeds right into tic severity. We're trying to outsmart tics through muscle contractions. Doug Woods has done some nice little studies where he has actually, in an experimental model, gotten kids to suppress and then not suppress. And what happens is, yes, when they're not suppressing, their tics bounce back up, but they don't bounce back up above baseline severity. This old idea was is if your tics are at 8 out of 10 and you suppress them down to 2, when you let go, it's going to go to 14. Your head's going to pop off. It's actually going to explode. What happens is you can suppress, but it comes up again, but it doesn't come up as high as you would expect it would. My favorite is the bottom one. New tics develop when you suppress. So do you remember this Freud guy? Because he hypothesized that there was underlying conflict which drove all of our psychopathology, if you just worked on a symptom to make it get better, what would happen is that that conflict would drive a new symptom to pop up someplace else. That idea doesn't exist anywhere in medicine except psychoanalysis. Yet one of the critiques of this treatment are that if you suppress or get rid of one symptom in one place, that it'll pop up in another. So the people who are struggling with understanding this treatment are actually using an old Freudian idea about symptom replacement that we've discredited a long time ago from our symptomatic treatment. So it's one of my favorite ironies. Again, Doug Woods has done a nice little study about symptoms. When symptoms are decreased in one domain, you do not see new symptoms or other symptoms get worse in the others. So there's not conservation of tickishness. That really does look like if you work on symptoms in one domain that the other symptoms stay the same or go down too. So this is parent-specific advice. We want you to advocate for your kid. There is absolutely no question, but I'm advocating for a whole new set of things. So we were talking a little bit in the break. I want pediatricians to respond completely differently to the kid and family when the family comes in and says, you know, he's been doing this stuff with his eyes. I want them to take a family history of psychiatric disorders. I want them to inform the family that this is a marker for neurodevelopmental disturbance. Not every kid's going to have problems, but we want to screen moving forward for ADHD and anxiety disorders because those are the conditions that are going to happen pre-puberty. And you know what? We want to square away kind of mom and dad management of behavior within the home because we don't really want to set into process any inadvertent rewarding of tic severity. We want to make your home tight and clean from a behavior management point of view. That's how the first few tics should get managed in the environment. So that's what I'm advocating for. The old was provide support. There was this idea these kids were afflicted and victimized. But what I really want to see kids do is I really want to see them take on challenges. I want them to get bigger and stronger. I want families to be there with their support so that kids figure out ways to do stuff better. Provide comfort. Ooh, but be really careful about how you provide comfort. Because if you're inadvertently rewarding tic severity, you're actually working cross purposes with what? what you really want. Kids with Tourette oftentimes get protected, overprotected. And what I would be saying to families is, listen, your kid's got to live in the world with these tics. Let's figure out a way for him to go here, go there, go here, go there, and figure out ways to manage his tics in multiple different environments. He now has the basic skills of our behavioral treatment. Let's put him in a difficult situation and see if he can really use those skills there. That's a way of approaching kids with Tourette that we really haven't done. We've been much more on the protective, overprotective side. Don't think about your tics. We want you to be mindful. We want you to know your tics so well that you can outsmart your tics. Ignore them? Nah, don't ignore them. Pay attention to the antecedents that cause them or trigger them, the behavior itself, how you are consequenced for having your tics. We want you to know the quote-unquote ABCs. We all want to reduce stress. No. You want to stress-proof this guy. Life is difficult. You want him to have the richest, most able coping and adaptive strategies. So let's figure out how we can make him big and strong by using strategies to put him in different situations and reward him for taking on those challenges and being successful. We used to celebrate your specialness of Tourette. That was Oliver Sacks' contribution to the field, making people with Tourette decidedly human and unique and extremely interesting. What we want to do is, we agree with that, but we really want to get excited about kids who found the way to kind of manage their tic severity. If you think about this kind of difference in advice, it really sets up a different kind of home environment. And so that's what we're trying to get pediatricians excited about, families excited about. So you can use this treatment in a variety of different ways. You can do it alone as the first treatment. You can add it to meds. We actually had one young man who was on Pimozide for a long period of time where we actually were able to teach him this skill so he came off medicine. So as you decrease the medicine dose and the tics begin to increase a little bit, you can actually use that as an opportunity to teach the behavioral strategy. We're training nurses in neurology clinics so that the nurses can do this, and it's in a 20-minute format. I think it's 4 to 5 sessions or something like that. So when a kid comes in, the neurologist can see him, do the diagnostic assessment, and then get the nurses to do this treatment over time. We're doing a strategy for the really young kids. We thought that we wouldn't be able to train 4, 5, and 6-year-olds to do this, but we're actually able to train them, and they're having a pretty good time with it. So it looks like the downward extension from 4 to 8 may actually be useful too with some kids. So I've talked a little bit about what the assessment will look like in the future. This is the slide that summarizes that. Remember, tics are a marker for neurodevelopmental disorders. They should not be ignored. We should just increase our vigilance as medical professionals when we see somebody who tics. To say, don't worry about it, it'll go away, may be true, but it doesn't necessarily set up the situation. Every kid I've seen has been told to ignore it, it'll go away. But for some kids, especially the ones I see, it hasn't been true. And then all of the early interventions are about creating a kind of a hopeful and an empowering environment for kids. Parents who get successful with managing this within the home environment will take that information to the school and work with the school to manage it better. I would love to see the optometrist, the ophthalmologist, the ENT doc, the what other ones get in there early? Oh yeah, the allergists. I mean, all of these docs who see these kids would know what a tic is, and that they would be able to make the referral and do this kind of early guidance instead of exposing kids to new glasses or allergy treatments or other kinds of things that are likely not to be effective. And you know, if you think about what I did with that little 6-year-old, you know, if I've known my patient now for 4 or 5 years and he comes in with a new tic at age 13, and you know, it's a shoulder shrug, I'll look at him and say, what have you figured out? He said, well, I figured out I'd try this. I said, well, I like that part, but why don't you do this little adaptation? In a minute, minute and a half, we have started a relationship around tic management that started when he was 6 or 7, that takes 5 minutes to do when he's 13, and he's rolling. This is a longitudinal care kind of approach. It is not, I mean, we did it in 8 sessions in 10 weeks, but if you're starting at first few tics, you know, the first 6 months of tic disorder to begin to do this kind of thing, by the time you're working with that kid over years and years, you've developed a pattern. The parents will even get in on it. So they'll say, well, you know, I saw this new one the other day. What have you been thinking about your competing response for that one? Well, I thought about doing this. Well, my parents think about one. Well, let's ask the doc. The doc thinks about another, and you come up with a solution. It takes minutes to do. And pretty cheap. I do that stuff on the phone. That's how cheap that is. So that's the model, if you will, about how to take this kind of treatment and integrate it, really integrate it into the life of kids and families. So I don't know, have many of you seen this book? God, I love this book. Nix Your Ticks by Duncan McKinley. He also has a website. Are you ready? Life's a Twitch. He's got videos on there now. He showed some of those videos at the national meeting. The reason I like this book is because it's funny, and it's aimed at junior high sense of humor, which I still enjoy. So he says things to kids like, you know, if your tics get up in the morning before you do, your day is toast. So get up early, be prepared. If you've got a tic disorder, you got to exercise because exercise makes them better. You got to eat right because you got to be healthy. You got to be strong. If you're going to take this thing on and win this battle with the tics, you got to kind of be in the right place in the right time. So he says all kinds of stuff like that moms and dads like, but he says it in such a way that kids don't fight it or rebel against it. So it's about $35 for the book. It's not without controversy. We really worry about how people can misuse this information, particularly concerned about teachers. And now, I'm almost done. I got a couple minutes left. Has everybody, can you fasten your seatbelts? Yeah, that's it. Sit up straight. Get ready. Because what we've been talking about, right? A psychological disorder, neurological disorder, neuropsychiatric disorder, now a behavioral and functional disorder. Are you ready for the next one? A dental disorder. Oh, golly. So there's a couple of dentists who actually think about tics as a reflex. Not a brain disorder, but a spinal cord, upper spinal cord disorder. And so they think about it as, you know, the reflex in your knee, you hit and you twitch, right? They're thinking that what we're seeing in tics are really that reflex. And so they hypothesize that there is a triggering event that's physical that leads to the tic, right? So the two most, I think, notable characters are Brennan Stack and Tony Sims, and they're both in Maryland, Northern Virginia area. And what they use for treatment is a neurocranial vertical distractor. Oh, that sounds creepy. So here's what they say. So, you know, we asked, well, why does this happen at 7, 8, and 9? You know, when it kind of kicks in, 6, 7, 8, and 9. And he said, well, you know how kids' faces grow as they mature? You know, this part pokes out and some of it gets wide and it's this way and that way. And, you know, there's not this synchronous growth from a baby's face to kind of our adult face. And kids' faces sometimes look a little off. One part grows faster than the other. One of the things they suggested is there can be a misalignment of the jaw that occurs during this period of time because some parts of the jaw grow more or less than others. And what they're suggesting, I have facial nerve here, but it's actually the trigeminal nerve. They're suggesting that the trigeminal nerve, as it goes through the lower jaw, is the triggering irritation that goes back up into the brain. And all the motor stuff is within all the tracks for all of the different muscles in the body goes through a very small area in the brain, so that irritation as it goes back up the trigeminal nerve triggers a reflex in any variety of muscles. So facial muscles, which is kind of the most obvious because that's where the trigeminal nerve works, shoulders, trunk, body. So this is... Yeah, this is where it goes through the jaw, and it goes back up here into the brainstem. And there's just lots of both sensory neurons there, which would explain kind of triggering of the sensory sensations as well as triggering of muscle contraction. So what they do is they, I know this sounds pretty bizarre, but they sit with people in the office. Has anybody seen this on YouTube? That's where I get all my scientific information. I've mentioned it 3 times. So they do 2 things. One, they move the jaw down and forward. So normally your top teeth sit in front of your bottom teeth, a little like that, right? I guess it'd be more like that. So they want you to move the jaw down so that your teeth line up. I guess it would be more like that as opposed to this, right? And then what they do is they put tongue depressors. Everybody's working their mouth and jaws now. It's fun to see. They put tongue depressors. They start with 1, they go to 2, they go to 3, they go to 4, they go to 5. And you have to be ticking during this whole kind of assessment procedure, but when they get to the right depth or height of the tongue depressors, you see on the videos people look calm and relaxed and have their tics dissipate. So they take that distance and then they make a kind of a mouth guard kind of orthotic, if you will, like you have in your shoes, and put that in your mouth and separate and have it function in the back of your mouth, so it's off your molars, if you will. That kind of separates your teeth at that ideal spot. And what happens is people wear this dental orthotic. I kind of said, well, how do they talk with this stuff in their mouth? Or eat? And essentially what they say is they send them home the first night to just read aloud, get a favorite book or magazine, and just practice articulation, enunciation, all that thing with the thing in their mouth, because you're not supposed to take it out once it's in. You take it out to eat, but you put it back in. Long term, if you're thinking about a developing child, this orthotic may actually shape the ultimate growth, like braces do, shape the growth of the jaw so that you're actually helping it kind of take the proper position long term. But they've also talked about working on joint restructuring, just actually doing surgery to kind of reshape, to kind of put it in the right position. So this is a treatment that sounds fanciful to many. And, except the thing on YouTube is kind of interesting. When you watch a few of these cases, it's kind of interesting. So what these guys wanted to do is they said, we think we have a bona fide treatment here. We do not know how to study it, but we are willing to work with anybody to do a research study. Now, I have seen a lot of the quackwatch types of treatment. None of those guys and gals ever want to study their treatment. They do not want to put it to the empirical test. These guys have enough confidence in what they're doing that they're willing to let other people design the study to evaluate this. So the Tourette Syndrome Association has given us a little bit of money. We're writing the protocol now, and so we're going to do a clinical trial to see whether there's really any basis to this at all. When you think about it, having something in the back of your mouth that you might bite down on slightly on a day-to-day basis may be like diaphragmatic breathing, right? It may just be a competing response, exactly like, this is. So we've got Doug Woods involved, and he's going to help make sure that we're actually doing something special. But what's interesting when you see the tongue depressors is nothing's happening at 1, nothing's happening at 2, it happens at 3, doesn't happen at 4, doesn't happen in 5, go back to 3, it happens again. So there seems to be something about the depth that at least for me anyway, makes me think that it's not quite a competing response like you would see in hair reversal. The problem with me presenting this here today is that we presented it at the national meeting, and a lot of people are going to go see their dentist. And I think you just have to be, this is a closed racetrack, professional driver. Please do not do it home. Because we don't really know whether this is safe. So how could it not be safe? Well, if you put the wrong distance in, it might actually make things worse, right? So let us do the study. Let us figure it out. These guys say that most of the folks with Tourette also have temporomandibular joint disturbance, so they click. And he said, as soon as we see the click or we see that misalignment of the mandible, we kind of know that they're kind of bound for having tics. Because they started this by doing TMJ, temporomandibular joint adjustments, and found that when they did it in people with tics, their tics went away. So this was one of those serendipitous kind of findings. So this is their website. And if you do YouTube, you can see him tonight. I particularly like the treatment experience of patient number 1. He's kind of a bald young man who was doing white-knuckle tick suppression throughout the entire video until he got the proper placement of this thing in his mouth. So are there other behavioral treatments? You bet there are. Parent behavior management training, behavioral treatments for aggression, school interventions for kids, rehabilitation approaches, which are not very well developed for disabled adults. I'm going to keep going here. Is that okay? How many questions we got?
Only 3. Right now, none from outside yet.
Okay, I'm going to keep going through the rest because there's a bit more to do. These are the treatments for obsessive compulsive disorder. This is the best treatment study to date, if you will. The results here are not surprising. People who didn't get treated or got placebo didn't get better. Medicine alone or CBT, behavioral treatment alone, helped some, but using the combination worked great. The best part of this study for me was really how behavioral treatment worked at the 2 different sites. At the Penn site, it worked fabulously, and at the Duke site, it didn't work very well. What this means to me is that when you're thinking about using a psychological intervention, you have to use pros. Almost anybody can prescribe medicine well. But if you're going to do a psychological treatment, you've got to get people who are really good at it to do it. I joke sometimes, behavioral treatment's like art. There's good art and bad art. There are behavioral treatments, there's good behavioral treatment, there's not so good behavioral treatment. These are augmentation strategies, so when I see kids on complicated medicines, or when you're thinking about kind of having refractory obsessive compulsive disorder, you're going to see people thinking about adding other medicines to the stew to improve outcome. I get a lot of questions about pandas. It's not going away, even though the longitudinal studies suggest that it is a rare or unusual condition. And I think the reason is that people are still getting antibody titers, and there's a whole group of kids who have high antibodies. Nobody knows what to do with them, don't know how to understand them. And the temptation to use antibiotics is so great that we're still seeing kids with exacerbations of tics or high antibody titers getting antibiotic trials. We really think that people are missing the boat if they're not using conventional treatments for tics and anxiety disorders, OCD. The big issue for treatment of ADHD in kids is whether the stimulants increase tic severity. And I've provided a little bit of the background here on this slide, but the bottom line people should understand is that no, we don't really have very good data to say stimulants worsen tics. And it's based on this study as well as a couple of others. But the reason why this study is so cool as far as I'm concerned is that while clonidine, Ritalin, or methylphenidate and the combination all were effective in reducing ADHD symptoms, the side effect profile was 20% worsening on Ritalin or methylphenidate, 26% worsening on clonidine, and 22% worsening on a sugar pill. So what does that mean? That means if I give your kid any medicine, he has a 1 in 4, 1 in 5 chance of getting worse in the next 8 weeks. And it had nothing to do with the medicine. So guess what I don't do anymore? I don't start stimulants the last week of August. Because they're going to get worse in September because they're going back to school. And what will happen is it'll get blamed on the stimulant as opposed to get understood as an exacerbation that was predictable for starting school. I don't start them at the beginning of summer vacation. Same reason. I do them in the middle of a boring school year, March, April, May. I do my trials when everybody is in the rhythm of school. There's no vacation. There's no exciting holidays. Everybody's got that long blah feeling. That's when you try stimulants to see whether they're going to be effective or not. This is my informed consent procedure. The most important point is down here. The idea is that if you're treating a 6-year-old for ADHD, whether he's got tics or not, you may, during the course of that treatment, see tic onset or tic worsening, and if you discontinue the medicine, those tics may not go away at that level or go away at all. Families who start on stimulants absolutely need to know that there is a chance, because of the close time of onset between ADHD and tic disorders, that if you start a medicine for ADHD, tics may start in the context of that, and that discontinuing that medicine may not make that go away. It is just how the disorders have developed in time. ADHD starts a little earlier, TS starts a little after that, and what happens is if you treat the ADHD, you may see the onset, because that was what nature had determined was going to happen, and it may not necessarily be causally related to the drug. These are other medicines. They're doing studies now on the longer-acting versions. And this is the data from the guanfacine study that Larry Scahill did, looking at ADHD in kids with tics, just demonstrating some improvement there. So there are alternatives to the stimulants, but if you look at this, it's just not as good. These are not as powerful in reducing ADHD severity. There's been a report about Wellbutrin causing tics. One of my problems with this study is, yes, it may have, but was it in 20% of the kids who were treated with Wellbutrin? Because if it was in 20% of the kids who were treated with Wellbutrin, it could have been a placebo effect. If it was half the kids, whoa, that's kind of interesting to me. Now we got a real problem. We got half the kids who get Wellbutrin getting worse. If it was 5%, I would say, I don't care about 5%, because the standard now is 20% worsening on placebo. Does that make sense? But most of these studies never publish really the placebo or the denominator. They just publish the numerator. Atomoxetine also seems to work, but in the trials there's no signal of worsening, but there are case reports about worsening. But again, the issue was it in 20%? If it was in 20%, I ignore it. How do children develop behavioral problems? I'm going to give this just a couple of minutes and then we'll wrap it up. I think I probably have 5 or 6 slides left. Okay. Are you ready for this? Children develop behavior problems in just 2 ways. Come on, no smirk, no skepticism. All right. The biggest way is power struggles. Power struggles are based on negative reinforcement. You see how this language is now in our vocabulary? So I got my friend Billy, right? His parents asked him to make the bed. He says no. Parents asked him to make the bed. He says no. And the parents say, okay, you don't have to make it today. Billy was just trained to say no twice. Next day the parents say, well, I got him to gotta get him to make the bed. Billy, make the bed. Nope. Billy, make the bed. Nope. Billy, make the bed. Okay. Chill. I'll go make the bed. So Billy makes the bed that day. Now, what happened though, is the parent just got reinforced for the threat, right? Oh, golly. So now you got Billy learning how to say no twice and the parents learning how to raise their hand in a threatening way to get compliance. Next day, Billy, make your bed. No. Billy, make your bed. Nope. Hand goes up. Billy zips into the bathroom and locks the door. Billy. Come out now, Billy. Billy. If he's really quiet, drives most parents crazy. They hate to see a kid in a locked room. Just hate it. Okay, you don't have to make your bed today. Just come out. We want you to be on time for school. So now Billy has learned to run away and lock himself in the bathroom. Next day, the parent stands in front of the bathroom door. You get the scenario. He's collected that day, makes his bed. The next day, Billy doesn't try and get in the bathroom. He stands in the middle on the balls of his feet, poised. And as soon as the parent takes a step at him, he heads out the front door, he heads out the back door to run away. Now, it sounds a little silly to you, but at least in my practice, I've seen some parents chasing their kids down the street. And then they're running after their kid, mad, red-faced, and they notice that Mrs. Jones across the street is looking at them chasing their kid, and it's kind of like, Billy looks around and he notices that if he can humiliate his parents in public, he's got control of them. Why do they have no candy aisles in the grocery store? Because there is no parent in the world with a full basket of groceries who can get through that with an 8-year-old without a temper tantrum, crying spell, or buying them a candy bar. That's why they have those, because kids and families know that this kind of power struggling goes on. This just keeps escalating, right? Unless you do something effective to intervene. Parents ask me, my kid lies too. And I said, well, do you ask him questions? I said, well, yeah, how am I going to find stuff out? Well, like, what do you ask him? Like, do you have homework? What does he say? No. Do you buy that? Well, yeah. Well, okay. You just taught him how to lie if it's not true. My kid doesn't listen. It's one of my favorites. Do you talk to him? Do you talk too much to him? Because kids stop listening when there's a lot of talking. Adolescents learn how to sleep at their parents in the morning. So as parents harass them to wake up, they get increasingly better at sleeping through harassment. These are all behaviors that are learned in the context of power struggles. If you think about the kinds of things we deal with our kids, this is big stuff. And it all generates from these kinds of power struggles. So for a parenting strategy to be effective, you have to get rid of power struggles. Supervision is really knowing where the kid is, knowing what they're doing, knowing who the child is, knowing who they're with. And there are a couple of problems that are directly related to poor supervision. Are you ready? Drug and alcohol abuse is directly related to poor supervision. So when you hear about those NIDA commercials that say parents are the anti-drug, their involvement, they knowing where their kid is, who they're with, and what they're doing prevents kids from using alcohol. There's absolutely no question. Actually, a nice little study that took kids with alcohol problems and just taught their parents how to supervise. No 28-day alcohol rehab program, but just taught the parents how to supervise, and you saw kids' substance use rates go down. Teen pregnancy. It's one of the things we work on in the reservation. We asked our young ladies when they got pregnant. Do you know when they got pregnant? Friday night after the football game, romantic, outdoors, the moon. No. It was after school, on the couch, at the house where one of the parents was busy out running errands or working. Unsupervised. And most delinquent behavior happens between 4 and 8 p.m. at night, so vandalism and other kinds of stuff. It happens when kids are unsupervised. So this combination of power struggles, which teach children how to misbehave, if you will, and actually inadvertently get parents using parenting strategies that are coercive and inappropriate, is really what we see in families that aren't working very well together. And then, after they've been power struggling for a million times, essentially what happens is the parents begin to do this and this and this. They retreat from the fray, if you will, and stop supervising, so that kids who are in trouble with maladaptive behaviors, who are getting engaged with other kids who are in trouble in an academic environment, the parents stop supervising and behavior problems just begin to flourish within the teen environment. So we're looking for poor parental monitoring and discipline leading to behavior problems in the school. These kids have academic difficulties. They get rejected by normal peers. And if there's no intervention, they do negative peer group formation, which is gangs. Or more common is really the alienated and disaffected teen. These are the kids who think their parents are clueless, completely tune out, get involved in drugs and alcohol, fall behind academically. These are really difficult teens. But the treatment for both of these groups, if you will, is to go back here and to do essential parent training. So there are a lot of reasons why kids develop behavioral difficulties, but the link between mom and dad and kid outcomes and kid factors is really what moms and dads do on a day-to-day basis. Kids with Tourette are much more difficult to parent. So when I'm working with moms and dads, I talk about industrial strength parenting skills. Ordinary parenting skills are not good enough. You need extra strength. It's the same principles, if you will, nothing fancy, but just the same principles keeping to the fundamentals that work the best over time. So we heard a little bit about Ross Greene. I like Ross a lot, but there's a whole bunch of other books. These are what I call hard hat parenting books. These are parenting books that are really about discipline and organization and structure within the home. And I think for kids who are at risk for behavior problems, making sure that your parenting skills are up to snuff. All of these are really working off the same behavioral principles. They have a different flavor, different context to them, but they've all got the same underlying principles. If you're looking for therapists in your community, this has changed a little bit. This is the Association of Behavior and Cognitive Therapy, and this is the Academy of Cognitive Behavioral Therapy. If you just look up these websites, the people who join these organizations are the true believers. If you go to the I'm not even going to make that joke. If you go to some other website, you may get people who don't really believe in the cognitive therapies, the behavioral therapies, and they both of these groups have lists of providers within the community. If they say they don't do children, call that practitioner anyway and say, do you know somebody in our community who works with kids? And they will always know somebody in the community. So when the behavioral therapy became another part of our armamentarium for working with kids with Tourette, we added 35,000 psychologists to the group of practitioners who now can work with Tourette. It probably doubled to tripled the number of people who could potentially provide services to kids with Tourette. It is a huge improvement in what we're able to do. And then this is really a summary, and I'm going to go through the questions. Is this it? All right. Oh, gal. Can you describe the role of dopamine in Tourette, too much or too little? The idea is that it's more about sensitivity to dopamine than it is about too much or too little. So the medicines block dopamine, but it really isn't the dopamine per se. It's really the receptor sensitivity to dopamine that's the bigger deal. What parts of the brain are involved in TS? As functional imaging studies have been done. You know, people now there's locations, there's the circuits that connect those locations, and there's the neurotransmitters like dopamine that allow those circuits to connect. The disturbance is likely to be in any of those areas, particular brain locations, particular circuits, or the neurotransmitters that are involved in communication among that. And I don't think anybody's going to say it's here. When they do deep brain stimulation, they essentially put it in Grand Central Station, the intersection of multiple circuits and multiple anatomic parts, and where there's high densities of important neurochemicals, and they create a field of charge at that spot that's big enough to affect it all. This is not precise business, folks. Discuss gender differences and are there diagnostic issues for comorbid? Oh man, and premenstrual symptoms. More boys than girls, although when you look closely, there are probably more girls affected, but they're more mildly affected. From an ADHD point of view, it's more boys than girls. From an anxiety point of view, it's more boys than girls. From an ADHD point of view, from anxiety and depression point of view, it's probably more girls than boys, except prior to puberty, boys and girls are equally affected with anxiety. Premenstrual changes, just think about any kind of internal disruption of peace and harmony, whether it's an anxiety disorder, depression, whether it's premenstrual symptoms, any of that you would imagine could be associated with worsening of tic severity in an episodic kind of way. Excitement about going back to school, excitement about vacation, excitement about Disneyland, those are also internal experiences which can stimulate tic severity. Oh, who does Botox? Neurologists who do movement disorder stuff. How do you explain that tics provide gratification? Well, I don't think it happens very often because I think most people who have tics feel it as an adverse, uncomfortable experience. So for them to have a tic where it actually provides gratification, it's unusual. So that's why I use that example where there was something about the sound of the tic in the atrium that may have been of some pleasing quality to that person. I think if you ask that person up front, they'd say, I want to give that tic up more than anyone else because it's the most disruptive tic in my life. but it just didn't seem to happen in other places where there wasn't the kind of positive sound feedback. It's the best example I can use. I don't think it happens much in that area. What about stimulants and GAD? Oh, you know, when I hear about a kid who had ADHD and was started on stimulants and got worse acutely, what I worry is that they had the inattentive subtype of ADHD that was not diagnosed as anxiety, which is what it should have been, or was misdiagnosed. Those are the kids where I see increases in tic severity, where the stimulant gets added to an anxious kid, because adding stimulants to anxiety is like kerosene on a fire. So I am particularly careful before I start stimulants to make sure that there is none, absolutely zero anxiety in that youngster, because it's that a youngster where I worry they actually have the exacerbation of tic severity. Computer-based CBT, oh my gosh, this is a great idea. Doug Woods is working on this now. He's working with the people who, there's a very sophisticated computer treatment for hair pulling called trichotillomania. It's called stoppulling.com. Those folks have also developed a website for skin picking. It's called stoppicking.com. And these are beautiful, very sophisticated websites. And so Doug is working with them to figure out how to do the CBET or behavioral treatment using that computer profile. So it's on its way. Any correlation between Tourette's and compulsive behaviors beyond drug and alcohol use? Food avoidance, overeating, sexual addiction. You know, there are a number of behavioral issues that adults run into where they, like I said, in psychiatry, we get interested in things where people do too much. And we realize that people, you know, they work too hard to get too thin and they get way too skinny. We realize that, you know, as humans, we like sexual activity, but there are some people who become so organized around their own sexual activity, they get into trouble with it because they're not discreet and don't discriminate very well in terms of their management of their sexual behavior. How all this relates to Tourette and OCD and compulsive behavior and impulsive behavior. There's one guy, Eric Hollander, who's trying to draw up a schema that explains all of this with a single kind of worldview. I'm pretty skeptical of those because I think about these conditions as being multi-determined, not singly determined. And so I think we should, until the data is out, we should probably resist the idea that, you know, there's one condition that explains a million different behaviors in a variety of human beings, and try and understand individual people's human beings as best we possibly can, and then use evidence-based treatments as much as we possibly can to help people with their difficulties. Got a couple more? Wow, 4:13. How about questions from the audience for 2 minutes?
I just need to, they're going to stop it at 4:15 to do a little reminder before you finish.
Oh, and then you have to do a little something too? Okay. One question. Once? Yes, I knew there'd be one.
Why is there the association between this particular set of comorbidities and Tourette's?
You mean the OCD ADHD thing? So when they did...
It's not random.
No, it's not random at all. And the strongest evidence is really with a particular type of OCD. So, and this came out of family genetic studies. What they did is they looked at control families, and they looked at families with identified through a person who had a tic disorder. And what they found is that a particular type of OCD was more common in the families where there was a tic disorder than in families where there was no tic disorder. And the kind of Tourette syndrome that was there was really this evening up, balance, sensory kind of thing, like twice on this side, twice on that side, not the dirt, germs, and hand washing. There seems to be a signal for hoarding, so it looks like hoarding of you know, not so valuable things occurs more commonly in Tourette families than in families where they don't have tics or Tourette. So it comes from families, and it's based on that. The ADHD story is much more complicated, because if you think about a kid who has Tourette syndrome and has OCD, He'll have attentional problems because he's got OCD. He'll have attentional problems because he's eye blinking. He'll have attentional problems because he's got this thing sitting in his shoulder that makes him uncomfortable, and he's fighting the urge to do it, and it's very difficult for him to do. He's got a million reasons to be inattentive. And so there's the kind of ADHD that started before the tics, which you would think would be an independent condition, and there's a kind of ADHD that seems to develop after the tics, which could be actually related to the tics, and that's what the genetic studies show, whereas the ADHD that presents before the tics actually looks like it's an independent condition, not really genetically related. So these things really come out of those family studies, and I think I've used up all my time, and I said one question, we'll catch you later.
Thank you. All right. For everyone today that's watching the program, even if you're not wanting CME, which is the sheet, we do need you to complete this other evaluation form. This is required for this kind of funding for the program, so please complete that one form. And again, if for anybody that you know may not have seen it, this will be available for about 24 hours that they can get CME credits, and then it will just be available for people to watch. So again, I want to thank Dr. John Walkup. I thought it was just excellent, and I'm so thankful that we have him here. So thank you all, and for some of you there is another program after this, so there's a 15-minute break. Please go register out on the front again if you're going to stay for the second program. Thank you.